My name is Mohammed Yasin. I am one of the interventional and structural cardiologists at Trinity West Medical Center, and I've been working here for the last 14 months. I was born and raised in a coastal city of Pakistan called Karachi, which is at the same latitude as Florida, so slightly warmer temperature than the tri-state region here. I went to medical school in one of the prestigious institute of the country called Dow Medical College. After I completed my medical school, I come to train initially in West Virginia at Charleston Area Medical Center, and then completed my intervention cardiology training at Allegheny General Hospital in Pittsburgh, after which I started working as an independent practitioner at Trinity West Medical Center. So it's a very interesting choice. While I was in medical school, one of my favorite subjects was physics. And after I got familiar with cardiology, I can see there was a lot of principles of physics that were applied in the practice of cardiology, like getting hemodynamics, applying the laws of physics and equations in getting echocardiogram. So that was one of the facts that I was interested in cardiology more. And one of the unique thing about cardiologists is that, in field of medicine, you are either a physician or a surgeon. The field of cardiology allows you to have a best of both worlds. On one day, you can do procedures, you can do interventional procedure, structural procedure, and on the other day, you can sit behind the desk and take care of preventive measures to help your patients. And interesting thing about cardiology is that it has short-term rewards and long-term rewards. By short-term reward, you can fix somebody who comes in with a heart attack or who comes in with an arrhythmia, and you can shock them and bring them back to rhythm. These are the short-term rewards, but there are also long-term reward, like counseling them on smoking cessations, giving them statin to prevent future cardiovascular risks. So that's one of the good thing about the field of cardiology. One of the other thing that I like about cardiology is not two patients are the same. Sometimes you would decide to perform procedure on one patient, and on the other hand, you would see the other things about the patient and decide not to do any intervention. So thinking and solving these puzzles and doing the best for your patient is what make me love cardiology. One of the most memorable patient that I have has a very emotional and touching story as well. A lady that I took care of during my general cardiology fellowship, who was going through family circumstance, whose son passed away with the electrocution while working on the electric pole. And then she came in with an arrhythmia for which we have to shock her 80 plus times. By investigating further, we were able to figure out that she has a very unique cardiomyopathy called giant cell myocarditis. And eventually we were able to help her, send her to a bigger, higher center and evaluated her for transplant. And that is one of the emotional and touching story that actually made me love what I do, that we were able to figure out something by doing a quick MRI scan and able to figure out a treatment plan for her and get her out of her misery. So this is one of the very interesting aspects of cardiology. A lot of time, traditionally, cardiology and cardiovascular risk factors are typically associated with man gender. Despite a lot of promotion and a lot of work being done by American Heart Association to promote the education of cardiovascular disease in women, there has been only 50% women recognize them who know about the risk of cardiovascular disease and health, and only 13% says that they have any known risk factors. And this is despite all the efforts that is done in promotion of education among women. We also have to make sure that the number one cause of cardiovascular mortality in women is still heart disease. That is more than cancer, respiratory disease, Alzheimer combined, including accidents. So this is a very high risk of mortality in women, and about 400 to 500,000 between this number is the annual death from cardiovascular disease in women in United States of America. It's a big health care burden as well. So that is the reason why I want to work towards and help towards education and promotion of cardiovascular health among women. And there are some risk factors and some demographics that we should be aware of in order to be able to take good care of women who are going to be our mothers, our sisters, our daughters. So being aware of that, it's a very important thing to be able to take care of them. One of the interesting factor is that the presentation of cardiovascular disease, especially MI, since I'm an intervention cardiologist, so the presentation of MI in women, usually it is at higher age group compared to men. But if they present at age below 50, the mortality in women is higher compared to men. The in-hospital mortality from MI in women is 17% compared to 12% in men. So women are also at very high risk from cardiovascular disease and MI, which is traditionally associated with men. Like some of the risk factors that we should be working on to improve the cardiovascular outcome is controlling the risk factor, managing their diabetes, which increases the risk of cardiovascular disease about 4 times in women, managing their blood pressure, keeping their systolic blood pressure less than 130, controlling their cholesterol level with a target LDL less than 70 and HDL above 50, and obesity, which is about 30% of the women have diagnosed obesity in United States. So working on these risk factors is going to help prevent future cardiovascular disease in women. I think the other thing that I am passionate about being women health is I'm also advocate of using modern imaging technology to help our cardiovascular disease patient. One of them is cardiac CT. I'm board certified in cardiac CT. And the reason why I want to get better at this cardiac CT is because this is a technology I can provide this health system with. Cardiovascular CT has advanced tremendously from 1970 to today. We have now different scanning methods and machines available that can reduce the radiation time and reduce the time from emergency room to discharge in people, especially with low to intermediate risk for coronary artery disease. So that's one of the benefit of cardiac CT. In the upcoming guideline into 2021 chest pain guideline, that have increased the level of recommendation of cardiac CT in low to intermediate risk patient and decrease impact of traditional non-invasive studies like nuclear scans. So that's one of the things that I'm really passionate about and I'm an advocate of.